I'd like to just take a second and tell you why we put on the Healthcare Summit for the community this evening. I was brought in by the Healthcare District in January of this year. When I came in, I was aware of the difficulties that our Healthcare District has had over the last couple of years. I have a lot of experience in working with healthcare districts, hospitals, just like the Bear Valley Community Healthcare District, and so I felt like I knew what some of the first steps were that we needed to take. It actually was the recommendation of one of our board members, Sara Russ, one of the newly elected members of the board of directors, who was formerly the executive director for the Chamber of Commerce in Big Bear Lake and was newly elected to our board in November, actually came up with the idea that we should do an educational program for the community. And after I had a chance to think about that, I thought that that's really an excellent idea, because in my experience of working with other distressed hospitals, one of the key components is for the local hospital to engage with the community. I've done it in different ways. I've done it by creating citizens advisory committees and creating newsletter reports, but I really thought that Sara had the right idea of sponsoring an evening event where we invited the entire community to come and listen to a presentation on what the contributing factors are that brought our hospital, our healthcare district to the situation that we're in now, and what the necessary steps are, and also to instill confidence in the community that we have the board of directors and the management team in place that are prepared to deal with the challenges that we have right now. When we were putting together the plans for the summit, it was a bit of a challenge to get it down to a manageable amount of time that worked for the local population, people getting off work. We wanted to make it so that we had enough time to cover all of the pertinent facts and information that we wanted to cover, but not take too much time that it became a burden to attend. So we really spent a lot of time and attention to trying to identify just those key points, being sure that we did want to talk about the history of finances and the big picture of healthcare and the plans, and we kind of developed our format around those three key areas.
Well, thank you, everyone. Really glad that you're here. My name is Raymond Hino, and I have the great honor and privilege of serving as the Interim CEO for the Bear Valley Community Healthcare District. It's my pleasure and honor to welcome you all tonight to our 2013 Bear Valley Community Healthcare District Financial Summit. I have to give credit to our treasurer, Sara Russ, who came up with the idea for tonight's event. Thank you, Sara. In a few minutes, I'm going to bring up the chairman of our hospital board, Barbara Willey, who's going to do some special introductions. But first, I do have a few housekeeping details to let you all know. We would appreciate it if you would either turn off your cell phones or turn them to vibrate. We have special sections in the presentation this evening where we will pause for questions. So if you would wait until we call for questions, we will take questions. We'll try to limit you to 3 minutes if we can when we get to each of the question sections, and we'd like to ask you to come up to the microphone. We're also inviting you to submit questions on paper, and you can drop them in the basket there, and we will go through those, and as time permits, we will get to those questions as well. When we planned the my gosh, it's standing room only. When we planned the summit, we were hoping to fill this room, and my expectations have been exceeded. And I see there are people still in the foyer actually trying to peek in from the back. So thank you so much for being here. I wonder if we might start tonight, before I bring up Barbara, and pause just for a few seconds and take just a few seconds of silence to remember the victims and the survivors of yesterday's tragedy in Boston. So if you don't mind, can we just take a few seconds of silence? Thank you very much. Now it's my privilege to bring up to the front the chairman of our hospital board, Barbara Willey, who's going to do some introductions.
Thank you, Ray. I'd like to thank everybody, as Ray has, for coming tonight. And the first order I'd like to do is introduce the board to you. I am the president of the Bear Valley Community Hospital District Board. And over here I have Donna Nicely, first vice president, Barbara Espinoza, second vice president, Sara Russ, treasurer, Dr. Chris Fagan, secretary. This is Rudy Chute, our CFO, and you've met Ray Hino. And I also would like to thank Helen Walsh, the president of the Hospital Foundation, for attending tonight. I see Julie Grandy, I see Linda Lucayo from the Hospital Foundation Board, and from previous board members, Ron Peavy, Brad Summers, Otto Lacayo. I see Kurt Madden, superintendent of schools. I see Bob Chakowski as a council member, Jeff Matthews, city manager. I see Jay Obernolte as the mayor of the city. Thank you. I see Larry Walsh from the CSD board of directors here. And I see Jeff Willis, the fire chief, here as well. And probably other folks that I can't see. But I certainly do thank you all for being here. And tonight's forum is a summit, and the idea is to educate the community of the financial status of the district, the deficit of the hospital, the governmental reimbursements that have steadily gone down. As you probably are aware of, Medicare, Medi-Cal, AeroCare, which is a county-driven program. And just on the AeroCare, we have put out $560,000 or $550,000 worth of service, and we have been reimbursed $4,000. So that's $500,000 right there. There are many, many more issues like this that Ray and Rudy are going to explain to you, such as swing beds and clawbacks and different words that I'm not familiar with. But also the ultimate tonight is to give you our plan of action of how we're going to proactively deal with these issues and how we are going to stop the drain on the reserves of the money in the hospital. And I would like to take a moment to give you a little brief bio of Ray Hino. He is our interim CEO. He came to us in January. He has 35 years of healthcare experience, 20 of those years as a CEO in Mendocino, Tehachapi, California, Montana, Sun Valley, Idaho, Texas, New Mexico. And so we're very, very pleased to have him. And he has introduced numerous ideas since he's been here, which is a short time, along with one of the terms tonight you may hear is swing beds. And that was a new one to me, and but it's profitable for the hospital. And he has jumped in, feet on the ground, and just had to keep running since he's been here. And I would just like to take this opportunity now to bring Ray up to the podium.
Thank you, Barbara. I started really young, actually. I got my master's degree in hospital administration from USC when I was 24 years old. Started working in my first hospital at age 24. I have been working in hospitals for 35 years, as Barbara said. So even though I've been working in the industry for 35 years, I'm still a year away from my 60th birthday. So I'm still, in a lot of ways, young and growing in this industry. But it has been, it's been a great career. I've enjoyed it very much. I think that I have been able to add to the Bear Valley Healthcare District the staff and the board of directors and the medical staff through the experience that I've gained over the years. I think the thing that's probably been most helpful is the fact that for the last 20 years I've really spent it almost exclusively in rural healthcare. And so, as Barbara said, there's a lot of ideas and concepts that have been in use for rural for many, many years that I've been able to jump in and right away make some suggestions and some ideas for improvement. I have had the great honor of serving on several national boards. I've been able to represent the small rural hospitals both at the state level and the national level. I'd even got to meet Alan Greenspan a few years ago when I was serving on the American Hospital Association board. So it's been a real privilege to be able to represent our hospitals. I think I'm going to start tonight and just do a short introduction for you to our hospital. I recognize that most of you have been in the community for years, decades even, and probably need no introduction to our hospital. But just in case, I want you to know that we have an excellent hospital here locally in the community that provides fabulous services that I'm very, very proud to be a part of. Those services include a medical surgical acute floor, a 4-star skilled nursing facility, our surgery department providing both inpatient and outpatient surgery, our emergency department, clinical lab, imaging services including CT, ultrasound, mammography, physical therapy, our family health center, the rural health clinic, of which houses the Mom and Dad Project, which you'll hear plenty about tonight. During the presentation tonight, I think you are going to hear a continuing theme, which is the troubles that we're experiencing locally at Bear Valley Community Healthcare District are not unique to Big Bear Lake. They're not unique to California. They're not unique to even small hospitals. The problems that we're facing are facing all hospitals nationwide. The effects of the economy, the effects of governmental cutbacks, cutbacks in the Medicare program, the Medi-Cal program, a increasingly difficult environment in terms of insurance payments for hospitals. And so we hope, if nothing else, that when you leave tonight, you'll recognize that we're one of many hospitals that are facing these challenges, and hopefully you'll agree with us that we're taking the right steps in order to ensure that there will be a Bear Valley Community Healthcare District here for many years and decades to come to serve all of us in this room and our families and families for decades. The next part of the presentation is going to be delivered tonight by Mr. Bruce Garlinghouse, and I'm going to introduce Bruce in a moment.
As we were planning the summit, one of the ideas that I came up with was to bring in an outside speaker, somebody who had the broad experience and knowledge of what's happening in healthcare throughout the United States to supplement our local management team, our local panelists, somebody who could give us the bigger picture. I thought of Bruce Garlinghouse. Bruce is an executive with QHR. They're a national company that specializes in the management of hospitals, particularly in small markets. And I asked Bruce if he would just take 10 or 15 minutes and talk about the challenges that hospitals are facing nationwide. The point that I wanted to get across was that this is not just Big Bear Hospital. This is not just the community of Big Bear Lake. This is happening all over the country, and we're affected too.
We're very fortunate to have Mr. Garlinghouse with us tonight. Bruce, I've known Bruce for several years. He is with a national company called Quorum Health Resources. He has over 25 years in the healthcare field. Quorum Healthcare Resources is one of the largest companies in the United States offering services to hospitals, both big and large, throughout the country. So he brings with him a national perspective that we wanted to hear from in terms of what he sees as the environment and the landscape for hospitals. So if you wouldn't mind, please join me in welcoming Bruce Garlinghouse.
It's a pleasure to be here. I'm from Colorado, and I drove up this windy road, and I was looking for some snow, and I didn't find it. I think there's a little bit up on the hill. I'm an old ski racer, and I always say I'm an old ski racer, and 30 years and 30 pounds ago. But it's a pleasure to be here. I'm not being paid to do this in any way, shape, or form. I've known Ray for some time. I think this is a wonderful experience in terms of them sharing with you, from a transparent standpoint, what's going on. As Ray said, we work with probably 300 hospitals throughout the United States. And you're not dissimilar from what's going on in California, Colorado. We work in 44 states. But here are some of the issues that the staff, the hospital are dealing with right now. You have a number of issues, and a lot of it is related to Obamacare, the Affordable Care Act, as we see it, which is being implemented over a period of 10 years. The other thing that I failed to mention is probably 30%, 35% of the hospitals in California are losing money. I think you have also, as I understand it, been through a number of CEOs, maybe over the last 15, 20 years. I think you've had a number of organizations involved in your community hospital, for better or worse. But I think this is a very, very important asset that you have, and it's indicative in terms of the people in this room. But over the next 5 to 6 years, things are changing rapidly, and particularly from a reimbursement perspective. Some of the things that we're looking at are issues such as value-based purchasing. We'll talk a little bit about that. This whole issue of ICD-10 transition, we'll talk about this. And I'm sure Ray is going to get into this as well. But really the theme is you're not dissimilar from other hospitals, and you have tremendous challenges in front of you. This is a very wordy slide. It's probably meant to be. This is sort of a synopsis of the Affordable Care Act, all 2,250 pages of it. But it's being rolled out over 14, 15 years. But beginning in 2010, you see issues such as dependent coverage, up to age 26 is mandated. You've got readmission scenarios and putting your payment at risk. In 2012, pre-existing conditions, exclusions are prohibited. I don't think anybody's going to knock that in any way, shape, or form. This whole issue of exchanges, and I'm sure Ray is going to talk about that a little bit later, in terms of how do we provide insurance for the new people that are covered as we move forward. This is a very important slide in terms of what's going on. Ray and Barbara talked about reimbursement, and in terms of sequestration, which is mandated, we're automatically seeing a 2% cut in terms of what's being reimbursed. This is a synopsis of maybe a little bit larger hospital over a 15 to 18 year time frame. But it shows that on a 450 bed hospital, through year 10, they would see about a $12.5 million reduction in reimbursement. Now, if you translate that back into a critical access hospital, and I think Ray and Rudy are going to talk about that as an opportunity for you, you will probably see a reduction of between $2 and $3 million a year on an annual basis. As I understand it, your net patient revenues are probably in the 16, 17, $18 million range. So when you take a look at what's going on with healthcare reform, you're going to see a 10 to 12% reduction in reimbursement.
Would you mind using the mic? People in the back can't hear you.
Sure, absolutely. Sorry. The next thing that you're going to be encountered with is value-based purchasing. And this is a way that hospitals are going to be paid in the future. It's really a combination of lowering costs and improving quality. I think your folks will talk about metrics, certain metrics that you're going to look at the hospital, and that's core measures and HCAHPS. And those are the types of things that you're going to have to take a look at. Even as you look at converting to critical access, you're going to see the pay for performance models in critical access hospitals. In order to rebalance what's going on with Obamacare, again, there's a necessity to significantly rebalance your cost structure. And hospitals historically have done that through cost reductions, reductions in force, but you're really going to have to balance it between taking a look at your costs, your professional services, your purchase services, as well as how do you improve quality. And so that's a whole other issue that we're being confronted with. The need for physicians. It's incredible. You know, you take a look at the expected shortages over the next 10 years, and you see significant demand for additional physicians. This is specifically related to the demand driven by the newly insured through Obamacare. So what we're projecting through 2008 to 2020 is about close to 95,000 physicians needed in addition to what we have now. So there's a tremendous shortage going on. You know, the whole issue of increased consumer responsibility for payment, I think you're going to see higher deductibles in terms of health insurance and just more costly insurance options out there and mandated. And as it relates to your hospital, you're going to see increased bad debt, increased cost of collections, and that's something Rudy, I'm sure, is going to talk about. The other thing that the Affordable Care Act is going to stimulate is joint accountability for care. And so really, in terms of, I talked about value-based purchasing, how do physicians, providers, your staff work together in terms of being jointly accountable? So that's really an issue, and we'll learn more about that. One of the things that we see going on is really accelerated market consolidation, particularly in California. It's amazing. You've got hospital consolidation, hospital physician alignment, payer consolidation, payer provider consolidation. I think you've got some building projects. You have an enormous need for access to capital, and you know, as you walk through the continuum, it's really gonna tax you as an organization. And last but not least, I think Ray's going to talk about possible clinical affiliation strategies. And again, I talked about this being a very, very important community asset for you. So if you look at the continuum of control, These are the types of things that we're seeing throughout the country. You're probably a standalone hospital, you've got the most control on the left-hand side, but as you take a look at affiliation arrangements, types of issues, these are the things that you're probably going to look at, and I think Ray's going to talk about that in terms of a potential a relationship. So that's it.
Thank you, Bruce.
All right.
And while we are seating a few people, this is a great opportunity since I see that our auxiliary volunteers are doing a great job tonight helping us organize this event, and we couldn't do it without them. Please give our auxiliary volunteers a hand and thank them for not only the wonderful volunteer work they're doing today, but every day in our hospital. We couldn't do it without our auxiliary. If any more people in the back want to come in and have a seat, because there's still a few more seats available. If not, I will continue. I'm going to take a couple minutes and talk about this recent edition of Time Magazine. It appeared on March 4th, 2013. How many of you saw this edition of Time Magazine? Several of you. I read the article. It's not very flattering for hospitals, to say the least. Some of the lessons that were learned in that article, at least what I took away from it, is I think, first of all, that the current healthcare system is broken and hospital bills are too high. Is that any surprise to anybody? They talk about $1.50 for a Tylenol pill, $150 for a CBC, $7 for 4x4 gauze bandages in the facility. And they say that as a result of the high charges, hospitals are also experiencing very high profit margins and talked about an average profit margin of almost 12%. Some hospitals in the article, including MD Anderson, actually had a profit margin of 26%. I'm going to tell you some of the similarities in that article with Bear Valley Hospital and some areas where we're not similar. We're not similar on the 26% profit margin. We're not even in the positive as far as profit margin is concerned, and that's something that Rudy's going to talk about in a few minutes ago. But we are similar in the fact that we are one of the largest employers in the community, if not the largest employer. And it's noted in the article that the government is probably the most efficient payer of healthcare bills. It touts the fact that Medicare and Medi-Cal pay extremely low rates, and with private insurance being much higher. And so to the extent that hospitals like ours, which has greater than 57%, I think you'll see in a later slide, of government payers between Medicare and Medi-Cal paying extremely low rates, that's one of our problems as well. It does talk in the article about hospital consolidation, and as Bruce had up in his last slide, affiliation and consolidation, and actually says that's one of the problems in the system as well. As hospitals consolidate and become bigger players in the market with more leverage and clout with insurance companies, they're able to negotiate higher insurance payments. That is something that Bruce is correct. We will be visiting later on in our presentation tonight as to how an affiliation type arrangement could benefit us in terms of higher insurance reimbursements, which is one of our biggest problems. At this point, we thought that we would pause for a few minutes and ask if there's any questions from the audience before we move into the next segment of our presentation, which is going to have Rudy Chute come up and talk about some of the historical trends for finances at the hospital. Are there any questions? Yes, sir, if you wouldn't mind.
Excuse me, Mike.
Turn it on.
I don't think it's on.
Switch on the top.
Is it-
I think you need to turn it on.
Switch on the top.
It has to go up.
Destin. Okay, thank you, Ray.
Speak directly into it because it's kind of.
Okay. Thank you, Ray, and the board, for, first of all, for doing this for our community. I've lived here 30 years. My son was born here in the hospital, one of the children that was actually born here 29 years ago. And I didn't have a question. I wanted to make a statement, if that's okay.
Of course.
Okay, first of all, thanks to the board and everybody, and thanks to the community coming out. I think some people I've talked to have said, well, gosh, how did we get here? Was it, I'll use the word mismanagement or whatever and all that kind of stuff. I don't believe it was. I mean, from what Bruce just said, it's the industry that's putting the grip on us. And my statement is, leadership is about taking a look and learning from the past and setting the course for the future. And I see that as what you're starting tonight, is that's what you're bringing the community in. So I wanted to commend you for doing that. Tell us, my request would be, tell it to us straight. We can take it. I mean, if our hospital's at risk, we want to know. I plan to live here for a long time. I think other people do. We always believed the hospital would be here for us. And so you need to let us know what needs to be done to make sure that it is going to be here. And we'll all work together to make it happen. So thank you very much.
Thank you. What was your name again?
Michael.
Thank you, Michael. Thank you. Appreciate it very much. That is a fair request, and that's what we hope to do tonight. We actually do hope to tell it to you straight, to be very transparent, to talk about where our challenges are, what the causes are of our challenges, but also to where the opportunities lie to fix some of the problems and to ensure that we will have a hospital here for many, many years to come. At this point in time,
Right?
yes, please.
Yes. Before you start, with your background in rural hospitals, would you explain to our community what is the advantage of a rural hospital being in Big Bear?
That's a great question. I don't know if everybody heard the question was, what's the advantage of being a rural hospital in Big Bear? And there actually are some advantages. The main advantage that we're going to talk about in a few minutes is that there is, I'll let the cat out of the bag a little bit early. Back in 1997, when the federal budget was balanced under the Clinton administration, the Balanced Budget Act of 1997 included a new set of laws allowing for the creation of a new category of hospital called the Critical Access Hospital. In order to be a critical access hospital, you must be located in a rural area. You must have a hospital no greater than 25 acute beds. You can have skilled beds on top of your 25. You need to be at least 35 miles away from the next closest hospital unless you're located in mountainous terrain. We're located in mountainous terrain. And you must have a full-time 24-hour emergency room. If you meet all those requirements, you can apply for and be approved as a critical access hospital. Today, there are thousands of critical access hospitals in the United States, and I've been to a lot of them. I've known a lot of CEOs from those hospitals. Almost every single one I've ever spoken to has said that the critical access hospital program saved their hospital. Had they not converted, they would be closed today. We do have that opportunity available to us. We've never converted to critical access hospital designation here. That is going to be one of my recommendations because it's an opportunity for us to improve our Medicare reimbursement. It's not a magic bullet. You can't just convert to critical access and all your problems go away. It's still hard work, but the improved Medicare reimbursement and the improved reimbursement comes through cost reimbursement through the Medicare program. For those of you in the audience that are familiar with the way that hospitals are paid and or paid by Medicare, hospitals are paid by Medicare according to the diagnosis of the patient in the hospital. And the payment rate is actually based on regional averages. It doesn't have anything to do with the actual services provided in the hospital. It doesn't matter how many days in the hospital, how many tests or procedures. Medicare has already determined how much they're going to pay for a stay in the hospital. If the patient exceeds that length of stay or utilizes too many services or consumes more services than what Medicare had predetermined they're going to pay, then you go into the red. It's a very difficult environment for hospitals, and the reason for the Critical Access Hospital program is because when the Balanced Budget Act was passed, there was a concern that rural hospitals were going to go out of business. Cost-based reimbursement pays us the cost for providing services to Medicare patients. In the case of Bear Valley Community Hospital, we calculate It's at least an additional $400,000 per year in Medicare reimbursement. I have a few other ideas where I think we can do even better than that. But besides critical access, it's a lot of hard work. But that is an advantage of being a rural hospital. Yes, sir.
Two things that he brought up that are new in the nomenclature of medicine. One is value-based purchasing, and the other one is meaningful use. Can you elaborate on that a little bit?
You're going to have me give away my whole presentation early.
Well, I asked Rudy if he was going to talk about it. He said, no, I just...
Wait, I'm going to talk about it. But briefly, yes, value-based purchasing is a new initiative from the federal government, which essentially says we are only going to pay for quality. In the Obamacare, national healthcare reform, there are, again, cutbacks in funding for hospitals through Medicare, but the way it's done is based on quality. If a hospital has demonstrated superior or excellent quality, they will get paid more. If they have poor quality, they'll get paid less. Value-based purchasing means you get paid according to the quality of services. One example is the patient's admitted to the hospital and then for whatever reason ends up getting admitted back into the hospital in less than 30 days, the hospital's penalized for that second admission. And the rationale is that perhaps something went wrong during the first admission and the hospital shouldn't benefit from a second admission. The second question was meaningful use, and that has to do with electronic medical records and the initiative of the administration that the United States should be paperless for medical records for doctors' offices and for hospitals. The Obama administration is willing to put their money where their mouth is and help pay for electronic medical records called meaningful use. We're installing an electronic medical record system at the hospital which will be paid for through stimulus funds through the federal government in order to help us become paperless. Rudy, I'm going to turn over the podium to you.
We know that nobody likes to listen to numbers and statistics, but we really felt that it was important that we spent time during the presentation to help explain the actual data, because we wanted it to be not so much theoretical, but actually get to some hard numbers that a lot of people within the community we thought would understand and would appreciate. For that part of the program, we brought in Rudy Chute. Rudy is the Chief Financial Officer for the district. He's been here, been a part of the team, been a part of the community for about 7 years. He's been through the good years and the down years, and I thought he was the perfect choice to go through this part of the presentation. In particular, we wanted to show the community that this is something that did not happen overnight. It took several years to get us into the situation that we're currently in, and you'll see that we've had a couple of down years. We also wanted the public to understand that it will take some time for us to dig our way out as well. And so this part of the presentation I thought was very important to get into the real hard meat and potatoes part of the presentation of what the numbers are underneath the covers of the operation at the healthcare district.
My name is Rudy Chute. I'm the CFO for the hospital, have been since April 7th, 2007. Seems like it's 1907. What we're going to talk about in the presentation are going to be 6 items that are present on the screen behind you. And as we go through it, we'll talk about each of the items in much detail. The first slide is our surplus going from 2002 through 2013. What is surplus? If you're in for-profit or you have your own business, it's profit. Loss, same situation. But in a district hospital, not-for-profits, we call that surplus. And basically what we have is our rural hospital, as our guest speaker pointed out, is like a lot of other hospitals in the country. and here in California. And lately, because of the government cutbacks, various other issues, our tax revenue is not supporting our losses, and therefore we're beginning to eat into our surplus. And that, unfortunately, is a problem which we're going to go through and address. We presented a management operation improvement plan to the board of directors, and we've begun to implement that plan. The high point that we had in our surplus was in 2003, and basically what happened there, you see the spike, that we received $1,741,000 reimbursement retroactive when we opened up the clinic over in Bear Lake, which is a family health center. Basically, the state of California and in rural health clinics, you establish a temporary rate. And then in your first year of operation, you are awarded a permanent rate. You take the permanent rate that you're awarded and retroactively apply it to the visits. In our particular situation in 2004, that was $1,741,000. On a go-forward basis, however, it was all based on operations. We did very well until 2011 and 12 when we started to hit some losses. In 2013, we're really hitting the wall, and the operation is going down significantly, as you can see. Cash and investments. Cash and investments increased starting in 2007 to 2010 for several reasons. We improved the cash conversion cycle. What is the cash conversion cycle? It's how fast you can convert revenue into cash. That's from the day the patient walks into the hospital until you actually have the money in hand you deposit in the bank. We've improved it. We went from a situation where our AR days were in the 60s, they're now down in the 40s. It was a situation with our inventory, as you go through and see, it was on a very high side. So as we went through this whole process, we began to focus on how can we go to improve the cash collections. And you'll see in this particular slide, back in 2005 and 6, our AR days were in the 60, accounts receivable days, that's the number of days it takes to collect money, was 60 days. We're now down into the 40s, about 47, 48 days to collect our cash, which is quite significant. And if you're in a for-profit organization, you would be a star. Non-profits, they accept 55 days. Cash conversion cycle also includes our inventory. You go back to 2005, you see we had $633,000 in inventory. That's a lot of stuff that we had in the hospital. What is inventory? That's supplies, medical supplies, pharmacy, office supplies that is in the inventory. That's a situation where you have holding costs. It costs about 15% to hold that inventory. We reduced the inventory from $633,000 down to $450,000. I believe it's going to be a little lower than that, but right now that's the best projection. And that's a situation where we reduced it down almost $183,000. If you go through and you factor in like I do, 15% times 183 gives you about $27,000 improvement in our cash position just by reducing the inventory. That's another cash conversion cycle process. Our supply costs. Supply costs have reduced. We had a high point of supply costs of 9.9% back in 2003. Currently, our supply costs are dropping down to 3.8%. What that is, that's a situation where we just manage it. We're members of the Marinet Group Purchasing Organization. Group Purchasing Organization is an organization that allows us to buy a product, supplies, pharmacy, at the same prices as Loma Linda. In fact, Loma Linda is on our Group Purchasing Organization, so we're buying at the same price as they are. However, they get more in volume discounts than we do, but we do in fact comply with that process. It is a quite significant reduction. Operating expenses. Our operating expenses, as you see, have been growing over the last year for a bunch of reasons. Some of it is a cost push economic scenario where the volume is remaining the same, but their costs are going up because the cost in the economy, and it's a situation also a little bit on the manager side as well. So what we're trying to do is take those costs and manage them a lot better, and that's one of the issues with our operation plan that we submitted to the board. There's higher salary, higher benefits. It's a higher electricity costs, as we know here, it happened in our community, one of the highest in the country. Our insurance reimbursement. These are our insurance companies that pay us. And I'm going to lump those in with Medicare and Medi-Cal. Medicare and Medi-Cal aren't really insurance companies, but I didn't want to use the jargon third-party payer, so I just go through and say they're insurance companies. So you have Medicare, Medi-Cal, you have HMO, PPOs. We all deal with Heritage up here. That's part of the HMO process. We also have the uninsured. What Ray pointed out, we're at 55% of our revenue is controlled by the federal government. That's Medicare and Medi-Cal. Medi-Cal is a state-run program, but it gets its funding through the Medicaid program through the federal government. So they are in control of our life. And lately, they've been making it a little bit on the miserable side. I stay up late at night looking at this stuff and send out texts at 3 o'clock in the morning. Our bad debts. There's a direct correlation with our bad debts in the uninsured. As you take a look at this for the payers, we're at a situation where in 2009, as an example, our uninsured was 13%. You take a look at the slide, and in 2013, okay, our uninsured, which is we call it the other self-pay, which is uninsured, is 22%. Our bad debts in 2009 as a percentage of gross revenue was 8.8%, we'll call it 9%. Currently, we're running almost at 12%. So as our uninsured went up, so did our bad debt. These folks lost their jobs, they just simply don't have the money, but they can't qualify for Medi-Cal beneficiaries, so what happens is they turn around to be uninsured, and unfortunately they just can't pay the bills. This is not any different from other hospitals. As our guest speaker pointed out, the rural hospitals across America, we have a special problem. We have a higher uninsured rate than they do in urban America. You go down to East Los Angeles, everyone looks at White Memorial. A lot of the folks in East Los Angeles are working. They're blue-collar people. They have really good insurance policies. But up here in the mountains, we don't have it. We have industries that don't have the insurance coverage. And what happens is they turn into, unfortunately right now, into uninsured, which then translates into bad debts. Okay, thanks, Ray. The government cutbacks. We'll find about one of our cutbacks isn't really a cutback. They all say that it isn't, but it truly is. We'll go into that one. Assembly Bill 97. I tell Ray it's called the Draconian cuts. And it's a situation where, let me tell you something. We have a CMS 4-star rated nursing home, and it is really a gem. There's only one other nursing home that I ever want to go into. That's in Sun Valley, run by the Catholic Church for the priests. And it's Villa Cabrina. And I do volunteer work for them through my Italian American Association. And I hope that I can get into that facility if I do. Because let me tell you something, there aren't very many of them. It's because of the cuts, the margins are so thin that what happens is people just, they can't make a profit off of it. And basically at the bottom line, you have to make a profit to pay payroll. But AB 97 was proposed by our assembly, and it rolls back the costs, the reimbursement, to 90% of the 2008-2009 reimbursement level. Just think of that, 90%. They didn't give us 100%. They rolled back to 2008-9 and gave it 100. They cut it to 90% of that number. That's a significant reduction, not only to our facility, but to other facilities in the state. There are nursing homes right now, part of rural hospitals, are looking to close. There is a hospital in Orange County I was with a CFO having a discussion at one of our groups, and she said she closed her nursing home. And she dispersed the patients or residents into the community. Well, we can't disperse the residents into our community. They're going to have to leave the community, travel an hour down the hill to visit their loved one in a facility. And I don't think anyone down the hill, any of those services, has a quality that we have. The Medicare observation patients. This is where the government did not cut Medicare. However, if you're in a hospital and you're an observation patient, you're in a bed, you're in a room, treated by a nurse, are you an inpatient or an observation patient? People do not know. And all of a sudden you wind up with a bill at the end for drugs that you have to go through and pay for it. And then everyone goes through and they start calling the hospital, why am I paying those drugs? And Mary Beth Rasmussen and her crew get the calls. It's a situation where the government came through, saw an opportunity to go through and reduce inpatient stays, and they did it. And every day we talk about it. At our flash meeting with Mary and the crew, it's like, who's observation, who's not? And you just simply can't tell. It's very difficult, and it's a significant reduction. And as you get into as we see our inpatient days, we dropped. We had $56,000 in inpatient revenue for the month of February. Never in this hospital, my 6 years, has it ever been that low. It's just catastrophic. And we're not the only hospital that is suffering from it. AeroCare, the low-income health plan, is a county program. Great concept. It's for people who cannot qualify for Medi-Cal, but they need the help. So the county set up AeroCare. Good concept. However, at least in my opinion, they didn't think it all the way through for our hospital. We, as Barbara indicated, we had $550,000 worth of billing, and we collected $4,000. We have an opportunity through a program with the County Board of Supervisors to maybe collect $100,000. So you do your max, it's not a lot of money. It's supposed to be 30% of the Medicare reimbursement. My God, Medi-Cal rather, excuse me. And Medi-Cal reimbursement isn't very good, so they cut that back. And that's going to be now right now we're reserved for it, and that's one of the reasons why we have the loss. I feel that it's always more conservative to reserve and have a surprise and give it back rather than having to go take away. The Medicare contract auditors. This is another, I call it a gem. It's a situation where I used to do this for a living on the other side when I did workers' compensation. Medicare went through and hired auditors. They're called recovery auditors, recovery contract auditors. They go into a hospital and retrospectively review your files. You know, in the old days when we were auditing, we used to joke that as auditors we bayoneted the dead, and that's what they're doing. You know, we have to deal with the realities of today, but they come through afterwards and they audit the numbers and they take the money back. In our particular case, it's about $440,000 they took back from us. And again, we're not the only ones. Hospitals throughout America are having this issue. It's a multi-billion-dollar way that the government can get back. And some of it's correct, I admit that. The fact of the matter is, they are putting pressure on us to go through and do things in a manner which 3 years ago, it was okay to allow the patient in the hospital. Now they go through and retroactively apply that rule.